Hi, I'm Berry-Kravis. I'm the moderator of this panel. I'm from Rush, and hopefully you can hear me. I'm a pediatric neurologist and have currently 1, but soon to be 4 n-Lorem patients at our institution. And I think that's really what we're here to talk about, is how do we build a consortium of institutions that can do this kind of work? Because institutions are basically very rigid organizations that are not interested in change and are very interested in what things are going to cost them. And so we've all run into challenges at our own institutions, and we're going to kind of run through and describe some of those. I mean, for me, I had to meet with the legal department, and luckily I convinced one lawyer that he was really interested in our individualized programs, and he's since become kind of almost our personal lawyer in the contracts department. But when the n-Lorem contract came in, they were like, whoa, what is this? You know, we're going to have a master contract and add individual patients to it? Like, how is this working? So we had to have a meeting, and we've kind of worked through it, and I think that that kind of communication is really important. And then the financial people made me have a call with them to convince them that this would not cost Rush any money. And we've done some novel things like create an N-of-1 fund that philanthropy runs, and we've had work with we have a large network of coordinators for our clinical trials, and we had to convince them that we wouldn't actually cost Rush anything, that we would bury this program in our clinical research program. And you just have to do things like that, or otherwise the institution feels that they're going to wind up with the cost. And then the issue of billing insurance came up for procedures associated with doing an N-of-1 treatment, and we've worked that out too. But I think we have a group of esteemed experts here who are trying to navigate the institutional hurdles at their own institution, and we're just going to go one by one, and everyone's going to introduce themselves and maybe talk a little bit about the challenges they've faced, and then just kind of like I outlined, how you may get around those challenges and actually convince your institution this is something they want to do because it's really cool and it's the wave of the future. All right, I don't need to.
All right. Hi, so I'm Margot Cousin. I'm a PhD scientist at Mayo Clinic. I'm our N-of-1 therapeutics director within our Center for Individualized Medicine. So all that to say, my job is really to figure out how to translate novel therapies for rare disease patients. And obviously an n-Lorem is an amazing opportunity to do that for our patients. And I would echo a lot of the things that were just said, in that it's been a long road, and we've had an excellent team within our center to help facilitate the process. And for us, that's been invaluable. To have a team of, a project manager, a program coordinator, clinical research coordinators, a protocol specialist, as well as legal counsel, both internal and external, all to get us to a place where I think now we can, kind of operate and run, right? We can consent patients at the beginning that will encompass, basically everything up into clinical trial. And it's been really important for us to think about those clinical partners, and that's partners, right? So there's like really your patient champion, who's bringing this patient forward, who's maybe diagnosed that patient, who's really interested in making sure that we get these amazing treatment opportunities. But then maybe that's not your clinical trialist, right? So who's the team of people who are capable of doing intrathecal administration, who have access to our clinical research and trials units, who have connections with pharmacy, and all of those other pieces have been challenges in bringing that together to make it cross the finish line for our patients. So it's been a big collaborative effort. We've had support, importantly, from our center that's funded a lot of those people to help facilitate the process. And that's really separate from actually paying for the trial itself, which again can come from many different sources, benefactors, foundations, or, as best as we can, trying to bill insurance. So I think I'll stop there.
I'm Julie Zebro. I'm a pediatric epileptologist at the University of Michigan. And our program right now is a little bit earlier. We haven't actually delivered the drug to the patient yet. It's still in discovery. But in order to put in an application with n-Lorem, there is a section on there that says that you have institutional buy-in in order to make sure that the drug is going to be able to be delivered to the patient once it's developed. So to get through that process, I guess, as a relatively junior faculty, I had no idea where to start in a very large academic center. So I definitely enlisted help from multiple people. So this has very much been a team effort. So shout out mostly to Louis Dang, who's been my kind of co-PI in this situation. But we also dragged in a couple of our senior colleagues who have an interest in trying to move ASO therapies forward as well. And essentially, to get the institutional buy-in, we started with the Dean for Clinical Research, and she also didn't know how to do this, but she knew all the right people. So she was really a good stepping point where she basically said, we just have to get everyone in the same room, and she set us up a meeting with the Chief Medical Officer of the hospital, the Chief Financial Officer, and then some of the other academic clinical trials leadership as well. And before we're going into that meeting, I think we really tried to do our homework first. So we met with the n-Lorem team. We talked with Liz, we talked with Jen, just to see how they had done this at their institutions, so that we could go into the meeting with kind of as much knowledge as we could present to hospital leadership before to go into this process. So we presented our case, we presented the methods behind ASO therapies, and then we really tried to explore what we would anticipate as the risks and the benefits, not only from the patient standpoint, but also from the hospital standpoint, financial standpoint, and then also just the benefits of potentially being a leader in moving medicine forward, which is part of the hospital stated mission. And I will tell you, I think the CFO probably asked the most questions, and I think he asked me 3 times how much the drug R&D was going to cost the hospital. And I think he was shocked every time when I said nothing. So that was a big selling point from their perspective. But essentially they went back and ran their numbers and then and gave us a decision that they were happy to support it, which is great. So we're kind of waiting for the next steps to really see how this works to be able to hopefully move forward with additional patients.
My name is Horatio Kaufman. I'm a neurologist, a clinical neurologist at New York University at NYU. And we have one patient with familial dysautonomia, that's a single point founder mutation, that is currently receiving an ASO that was designed to correct the splicing defect. It's the 4th, next will be the 4th dose of the ASO that is given intrathecally. I was thinking this morning how to summarize the challenges to make this happen, which took a long time. And perhaps I thought in three principles. Number one, the FDA is not the Vatican, meaning they do change their opinion if you refute an initial. We had 3 refusals and 3 no's saying we couldn't do it, and finally we got it approved. So remember, if they say no, don't take no for an answer and keep arguing. That's probably number one. Number 2 is that every institution, at least the ones I know, particularly the ones that are supposed to be the best institutions in the US, have been infiltrated by middle management whose job is to say no. Whatever you say is going to be no. There are now 3 to 4 to 5 administrators per investigator. The job of these administrators, nobody knows. I think that their main job is to say no. So do not take no for an answer, because you could convince them, right? And the third is rely on use n-Lorem resources. This is an incredible organization. I have worked over the years with many foundations. I don't think that any foundation compares to n-Lorem. And perhaps the big difference between n-Lorem and others is that most foundations are, they only care about the financial part. They give you the money or they don't give you the money, and then that's it. n-Lorem actually is, I think, is closer to a program officer for an NIH grant, meaning they do support what you do, and they have been incredibly helpful, not only in refining the protocol and helping, also in the relationship with the FDA And essentially, they have been extraordinary. They do help with everything, and they have a team that I think is equal or better than program officers at the FDA. How is this paid at the institution? I think it remains a mystery. And I think it's better to keep it that way. When the institution asks you, well, what would happen if there's a complication? Who would pay for that? I think the best way is to go around in circles and essentially give no answer, because nobody knows who would pay if there's a complication. So keep it like that, hope there are no complications, and keep going forward. Keep the high moral ground. What you are doing is not for your benefit, it's for the benefit of somebody else. And whoever says no is really preventing helping a patient. So keep that high moral ground, because you have it when you want to treat a patient. Keep going forward, be inappropriate if you have to be inappropriate, but don't get fired.
All right, my name is Luke Hamilton. I run a research data science and analytics team at Cook Children's in Fort Worth. We effectively conduct investigator-initiated research, and then I'm also developing a precision medicine research program. I think I'll just kind of reiterate and paraphrase things that have already been said. Nothing's necessarily original, which is nice to hear when you feel like you're kind of doing this alone at your institution and figuring out how to proceed. But it seems like every institution is kind of going through the same hurdles and traps. I think the big points from our side are get it in front of the right people early and continue to follow up often. This is a novel thing that nobody's ever seen before. And I think the second point that Horacio kind of mentioned that I'll paraphrase differently a little bit. People like to say no to new things, but I think the way that we've taken this is if we assume positive intent from everybody, we assume everybody's on mission to help children, right? We just need to find a way to communicate what we need from them in a way that makes sense to them. So from the clinician and scientist standpoint, we're very focused on the single patient, ensuring that patient is treated well and successfully. But from the institution standpoint, I think what they're thinking, from just our perception, has been in order to treat the patient well, we need to be able to be in a position to treat every patient. And so they're worried about institutional risk and financing and how that may affect the system. And then I think the second point to that is the people, the middle management people that are often saying no, are trying to find a way to help with the tools that they have available. So the legal team is going to be concentrated on risk. I know we were very nervous to go to our little institutional review board with this new thing that has limited preclinical data because we knew kind of what the answer was going to be when we went to them. But when we broke it down into digestible parts to say, okay, we're going to break this down. It's not a linear pathway from discovery to administration. We're going to break it down into two separate parts where discovery is going to be the skin biopsy that's investigator initiated, and then n-Lorem's going to help us with the FDA submission. That was a little bit more well tolerated. But I think those are the two big points from us. Just be early and often with administration and find ways to communicate to them that will get them to understand that they need to use the tools they have in order to say yes and not no. So.
Okay, thanks everybody. I think that one of the things our lawyers had the most trouble with the contract is the concept that they were signing a contract that's almost like a template contract, and there were going to be individual statements of work uploaded for each patient, and they're kind of signing on to something that they don't know what it is yet. And I think that was one of the things that was really challenging to talk through with the lawyers is how is this working and why is it important? And how can we sign on to something where we don't know exactly what will be done in the future? And so I did wind up talking them through it. And like I say, we have a lawyer now who's like our personal programs lawyer, because he got so excited about the idea that he was going to be reviewing these very important projects for kids. And I think often lawyers just they have this stack of paper on their desk and they have to read all these contracts and they'll kind of get to it when they do, but they don't see the downstream, like they don't see how they're actually impacting someone by helping the doctor with moving this forward. And I don't know if you guys had any specific dealings with your contracts people. The other thing contracts people are really worried about is where is the data going and who owns the data, and et cetera. So maybe if you guys have any comments on whether that actually came up in your discussions or not.
I mean, for sure, all that came up in our discussions. As you might imagine, Mayo Clinic's pretty conservative and very concerned about, patient protections, as all institutions are, but also, their data is a big deal. That patient data is a big deal. So understanding what the handoffs were, where the data was going, that there was, is there money changing hands? Is, who's getting what data? What partners are engaged with n-Lorem? Where are those samples going to go? And I think once you break it down and have enough of those conversations to really understand what's happening, which also helped us, right? Like having our legal ask all those questions really helped us understand the process a lot more so we could engage in the right way. It took a long time. I think we started with an MTA just to get going for our first patient. And then it was, months of legal review and outside counsel and all of that to get to a point that everyone felt comfortable. And I don't even think our contract is that complicated in the end. It's pretty simple, but it took a while just to get everyone on board. So again, having those conversations early and just continuing to walk down the path, right? It's not if, it's how. And you can get there. But now I think it's a lot easier. We have that in place. When a new patient comes, initiating those statements of work is not a big deal. We understand who the key players are and how that goes. So that first contract was a struggle, but definitely achievable. And I think it gets your institution on board because now you've kicked the tires, you've seen the partners, and then actually you really see the strength as opposed to the risk, I think, at the end of the day.
Yeah. Absolutely true. The first one is the critical one.
I'm learning a lot from this because we haven't dosed our first patient yet. So now I know we need to go to legal now. So legal was in our initial meetings, and surprisingly, they didn't actually bring up anything else at this point. I know we have to do the contracting aspect, so maybe we should start this now. But we, have a MTA and the release of information from patient and things like that.
Interestingly, and I was surprised myself, the legal part was the easiest. In fact, I think the lawyer liked the idea, or we knew her well, and that was even faster than any other protocol. Also, perhaps as you mentioned, was because NYU had a previous contract with n-Lorem for the treatment of an intractable epilepsy with the epilepsy division. So they sort of rubber stamped that. So after that, I thought everything was going to be as smooth. Well, did I get a surprise, right? So it wasn't. However, things slowly got better and we finally did it. So I repeat, it's all possible. Just keep pushing, and it happened, and rely on n-Lorem support, even for that, even for your internal process, because they are really extraordinarily helpful. I would re-emphasize that.
I think from the Cook standpoint, we've been more like the first two presenters in which the contract has been probably the most difficult part. So Cook has engaged outside counsel in order to kind of understand what's going on. This is a novel thing that they've never kind of encountered before. I think two big things on the contracting front are, number one, educate. So get them to understand like this compression of the distance between clinical care and research is coming, and it's only going to accelerate. And so if we can start to be forward thinking now and understand that if we can get this contract set up in a way that will benefit additional patients, we're going to be in a good position. But yeah, it's been an interesting process. I think the second point is definitely to engage n-Lorem when they're available. So as Lori mentioned in her previous presentation, part of our job is kind of to get that institutional buy-in. And so on day one, we meet with our legal team and say, hey, n-Lorem's available to meet with you. And then this goes to outside counsel and they start, going back and forth. And we say again, hey, n-Lorem's available to meet with you if you'd like to talk to him and get some of this straightened out. And we're 7 months down the road now, and we're still offering that same thing. And we finally, as I was flying in here on Sunday, we got a message saying that, hey, our legal team would like to meet with n-Lorem. So we're finally moving. But yeah, again, I think it's just assuming positive intent and educating, getting the right people in the room together. So
yeah. So in the data conversations, one of the things that I think is very helpful is that n-Lorem has a REDCap database that we're entering de-identified data into, and since our institution, of course, is familiar with REDCap and is familiar with other projects that enter data into REDCap, I think that made the data discussion, a lot easier, just because they were kind of familiar with how that data would be collected and so forth. So, some of it, if you can talk around something they're familiar with, I think it does actually help get through the process. It sounds like everyone has the same basic issues, the IRB, the risk. We didn't have much problem with our IRB because I've done a lot of expanded access before, and so our IRB was used to these weird, N of 1 things I was doing. But I don't know if you guys have anything that's been an issue at your IRBs.
I think it was a challenge to strategize on what that first IRB protocol would look like, right? To allow us to consent patients to share samples and data for, research for drug development. So that took a little bit of thinking to make sure our patients understood what they were doing and that we weren't investing in something that maybe they didn't want, right? So do they understand what's happening at n-Lorem and that they're really wanting to engage in a clinical trial for an experimental therapeutic at the end. So making sure that consent form made sense, but it was still open enough to allow us to, expand and grow and change as we move forward. So that, we have essentially an overarching protocol that allows for intake and all the research and development, and then, each patient will have obviously their own IRB protocol for treatment. And we have 2 other patients being treated at Mayo that didn't necessarily go through my program because they had already initiated the process, but they have definitely helped us as we try to standardize kind of how we're doing things moving forward. So I think I'm getting messages that I think we're hitting submit to actual IRB today for our current patient, but we've made it through all of the other regulatory committees and all of that, so that's where we are.
I'll just say we have our IRB kind of on board early. They were at our initial meetings, and they are notoriously slow, and they know this, but they're getting better. And they have kind of reassured us that they want to move this in an expedited fashion when we're at the time of IRB submission. So I think just having them kind of aware that it's coming down the pipeline is helpful.
I think I'm always re-emphasizing the same. What we thought was useful was also inform the IRB and the institution the fact that we were not the first ones doing this, that is not a commercial company doing it. And initially the confusion, and then n-Lorem changed that, was that this was an investigator-initiated IND. So the institution is much more benign with investigator-initiated IND rather than pharma. When this was changed to n-Lorem, what they couldn't understand initially was, but is n-Lorem pharma? Well, no, n-Lorem is not pharma, it's a foundation. Why a foundation has an IND? Finally, I think they understood that was our only sort of little difficulty. And then I sent a lot of even press on n-Lorem and what they were doing and what they meant. And I believe that helped tilt the balance, saying, it's not fully investigator initiated, is a variation of that, but it's not, number one, they have to understand that this is not for drug approval, for FDA drug approval. There is no commercial path, and as you mentioned, that money is not going to change hands directly with this, and that the goal of n-Lorem is not to get FDA approval to sell this drug. I believe that increases the sympathy, to use a funny word, increases the sympathy of the IRB board to approve these. So I would emphasize that a lot. The n-Lorem is not a commercial company. And again, I believe that makes a difference.
We're having the exact same conversation, it's just a little bit earlier right now. So Cook has historically had a pretty robust investigator-initiated pathway for single patient INDs. And then we have a pretty robust expanded access program as well. This kind of fits right in between those two paths where we're not acting anymore as both the investigator and the sponsor for the IND, and the change in having a sponsor for these has kind of adjusted our submission route. But the IRB has been wonderful in working with us in creating that. So exact same conversation, just different variant as to kind of how we get to the outcome, but it's been positive, although it's been some work to get the education on the front end about the differences and intricacies. We're getting there. So.
Yeah, we've had a lot of difficulty with our institution understanding who the sponsor is also. Have had to clarify that multiple times. And in fact, I am still the sponsor, the PI of all the, I'm still the, we send everything into the FDA and we sponsor it. And part of that is I have this house of cards I built at Rush where if it's an N of 1 and if I'm the PI, there clearly is no place for the bills to go. And so when they want to say, oh, that should be billed to a research account instead of to insurance, I just, there's no place to bill this. And this is what we do in EAP. We bill insurance, and this is N of 1. And N of 1 has now become a word that I can use with them, and then they just erase all of those obstructions to insurance billing. So we've been able to get past that, but I'm afraid if we changed it and made n-Lorem the sponsor, then suddenly they would be like, oh, well, these bills can all go to n-Lorem. Then obviously that's not going to happen. So I think it has been, you really have to dig into these intricacies, or they really don't understand it.
Sure, sure. I emphasize the same as you said. Even simple thing, even bills that are, let's say, if it's a pharma-sponsored project, the IRB wants their $5,000 fee. To build the data master, you have to pay $20,000. Whereas all those things, if it's investigator initiated, you don't pay them.
Right.
Now, if it's a foundation is the sponsor, there is where there's a lot of argument, and I don't think it's fully solved.
Yeah.
Right.
Yeah, no, not fully solved. I mean, they asked me about the IRBs too, and I was like, we know those IRB fees are just kind of funny money at Rush, and seriously, I've been donating my time to the IRB for 20 years now, and you're going to ask me for IRB fees for my N of 1 project? And so we got around that, but it is a challenge, and I'm thinking, we have like 4 minutes left here, and I'm wondering if anyone in the audience wants to ask a question about some of these institutional hurdles, or we can try to answer questions.
Hi, this is fascinating and really helpful, so I'm glad we got the opportunity to do it. I'm just wondering, like, if there's talk of N of 1 to N of many, right? That's a concept that's being discussed. And I'm interested in how potential transfer of an IND from an investigator-initiated trial to a sponsor what that might do from an institutional perspective to the continuity of the clinical work.
That's an interesting question. I mean, we're starting an N of 2 coming up, and the ASO that we're using, if it's safe and it looks like it's effective, could treat basically everyone with the condition. So there could be 50 to 100 patients in the USA. And so if there was, depending on what the regulatory path turns out to be, if there were a sponsor, we'd have to transfer the IND, or do we have to even make it a different IND? Because our IND right now is for an N of 1 trial, which according to the FDA is 1 or 2 patients, although we now know that additional patients have been able to be added on to those. So I think there isn't a regulatory pathway for that right now, and I think that is what we're going to do in the next couple years, is figure out what is that pathway. And obviously there are quite a number of diseases that are like that. But how would we transfer? I think that would be in many ways up to the FDA. What is that process, and what does the IND transfer look like?
I do think what we've learned is that you can, one IND can reference previously submitted if it's the same product. I think we learned that a little bit earlier today. And that's one of the strengths, I think, of this happening within a foundation and with academia is that it's not by a pharma sponsor that's really going to have kind of blocked walls, right, to allow groups to do that. So I think there's a strength in this community because of that. And certainly within n-Lorem, being able to reference their own programs should be able to expand it. But again, I think the regulatory landscape there is still pretty poorly defined as how we go from 1 to 5 to 10 to 50.
I'd like to ask a question and also share a story to illustrate the question as well. So the question is going to be, how do we improve clinician education around genetics so that we can improve diagnostic and access and identification of N of 1 patients so that we can more increase the identified population to really highlight the need. So the story I'll share is that our son Lucas, in many ways we got lucky that our diagnostic odyssey was not as long as many are. He had a cleft palate at birth, so naturally it was seen as more likely to be syndromic. So by happenstance, they ordered a whole exome sequence searching for cleft-related syndromes like Stickler's and others. And by happenstance, they found an ultra-rare disease with 60 known patients in the scientific literature, with only one having a cleft palate. And what we hear very often from clinicians is, well, I don't want to order a whole exome sequence because I don't know what I'll do with the results if we get a diagnosis. So I'll return to the original question. How do we increase access to whole exome and genome sequencing and increase clinician education to be comfortable with the genetics? Thank you.
I can say this is a really challenging question. In pediatric neurology, we are doing our best to at least educate our residents as they're coming up, but that doesn't necessarily help some of the clinicians who have been in practice for a very long time and are still very intimidated by genetics. So we are trying to expand our curriculum. We have online curriculum for pediatric neurology that just came out this year through Child Neurology Society. But I think you make a great point that especially some centers don't have access to all of these different testing modalities. I know some states are expanding their ability to do further testing. So the state of Michigan now has rapid whole genome sequencing for critically ill children, which I think has been expanding our diagnoses much better. But again, you have to be probably in an academic center for those things to happen. So I wish there was an easy answer, especially I would love to start educating our adult neurologists more too, because we know that there's so many patients who are missed.
Perhaps one should also emphasize that whole exome analysis or even the whole genome should be done much more frequently. It's not. Many neurologists or clinicians believe that asking for that is really a failure of making diagnosis and should be like the last resort. I think with the progression of medicine and the reduction of the cost of the test, it will be much more easy to do and much more frequent. And I'm old enough to remember when asking for an MRI, even a CT scan, required you to know the diagnosis before. Nobody does that now. You don't spend 5 hours saying where the lesion is, you ask for an MRI. I think with the explosion of genetics, there's no way to know all the genetic diseases. From the retina to the brain, there are thousands of them. There's no way that a clinician should know them, and I think there should be no stigma about asking for whole genome. Perhaps that will make a difference, and the reduction of the cost. When Steve Jobs, the Apple guy, did his own genome, that was $1 million. Now it's $1,000. So if we keep going, and this is a few $100s, I think it's going to be a routine test.
Yeah,
right.
It's a routine test in our clinic. The residents and medical students all get to see us run around with the GeneDx mouth swabs, and anybody we don't know what they have, they get swabbed.
Even if you know.
Even if I know too. Yeah. Okay, so we are over time, and so we are going to end the panel. And anyone who wants to ask any of us questions in break time or whatever, feel free.
Thank you.